All right, looks like we're shutting the door. Good morning, everyone. What we're going to be talking about today is healthcare IAM and the challenges with IAM in the healthcare industry, right? I think we're on the cusp of a huge shift coming here soon. As you'll notice, we changed the title of this presentation. It was, oh shucks, not another breach, specifically looking at healthcare, but given the last month and a half or so, I kind of felt it was poor taste. We've had a couple of very big, very visible breaches, so kind of highlighting that just seemed like poor taste. So my name is Nick Hunt. I'm the Director of Delivery for IDMWORKS. I've been in the healthcare and IAM industry for about 20 years. So in and out consulting. I worked at a hospital for a number of years. Different kind of verticals, inside the healthcare. So from an agenda today, give a bit of background, why we're talking about healthcare and IAM, right? I'm going to take a step back, given the change, ascension, all the other stuff going on right now, I think there's some very quick reactions we all want to make, and even some of the headlines coming out right now are all very reactionary. The regulatory environment's probably going to change. So if we move really fast, I don't think we're going to solve the problem here. So I want to take a step back for a minute, do some root cause analysis, right? I'm old school developer, network nerd. You have a problem, let's figure out what the problem is so we can fix it, right? Talk about the healthcare IAM renaissance. I sat in a session here with mobile credentials a minute ago, listening to that. These types of things are coming very fast, and healthcare is probably going to be one of the bigger consumers of this. They're primed right now to kind of make that next big leap. And then some closing comments and questions. So this headline was taken right after the Change Healthcare. I mean, we all know what happened. Citrix interface didn't have MFA enabled, so everyone's immediately jumping on, we need MFA, right? Honestly, is it really needed? Is adaptive MFA needed? Are stronger protections? Do the vendors need to support modern authentication? There's a whole host of things we could talk about here, not just MFA. So like I said, the quick reaction is, enable MFA. Is that the right answer? Well, we'll talk about it. And then I included a bunch of other example breaches. I was actually just reading before I got in here, Change Healthcare affected over 50% of U.S. citizens. From a data exfiltration. I mean, one incident right there. Pretty much everyone's affected. So I threw a quick quote up here, mainly about this. Kind of let's pause for a second, take a look at the industry. Why are we having these challenges? It's important for me because I'll bang my head all day trying to figure things out. At the end of the day, we need to take a step back for a second and say, okay, what is the root of this problem? And then start building solutions around that, right? So let's take a step back for a second and do some root cause analysis. So of all the challenges in healthcare, what do you think the biggest is? From an IAM security, just in general. It's culture. Attackers are going to go after vulnerable people that want to be helpful. At the end of the day, users want to do their job. They want to be enabled, right? Specifically in healthcare, a lot of people I talk to, they got into healthcare because they want to help people. People are very vulnerable. They're in bad situations. A lot of healthcare workers want to be that helpful person. Attackers know this stuff. Go look up YouTube and all the phishing against healthcare help desks and some of the stuff they spew out when they're calling in. It's pretty interesting. You have strong personalities. Doctors, very kind of public people, they want to do things the way they want to do, right? We make jokes about C-suites and everything else. Think of a whole industry of C-suites, that their primary focus is providing care, not the technology or the actual doing the care, the back end of it, right? A very, very, very diverse workforce. You can go all the way from a volunteer to a doctor to a business leader, looking at the bigger health systems. And on top of that, the actual consumers of this industry, are very, very diverse. You look at a lot of industries, well, they're mobile first or it's generational, everything else. You can talk a kid and a family all the way up to, my father-in-law that doesn't even have a mobile phone, right? So when we start talking MFA and all these other advanced topics and everything else, it's not going to work for him. So as we're thinking about these things, we need to think what's going to work across that breadth of people. And then workforce users that are overburdened. I hear terms like click fatigue, care fatigue. The amount of time someone actually spends bedside versus entering all the data and actually administering that care behind the scenes, it's swaying too far, right? So how can we take a look at what we're doing today to help that? Risk averse. Healthcare, most people I talk to, they've got very, very, very strict change windows, and their focus is pretty much on availability, stability, not features, functionality, the whiz-bang, hey, we're going to do this cool thing, right? If it's stable and we can provide care, they're going to stick with that. And they're always at least a couple revisions behind the industry. Healthcare is interesting in the sense that they'll stick with what works for a long time and then they make these huge leaps, right? That's why I say I think we're right on that cusp of this huge leap from an industry perspective. And then tight margins. Do more with less in healthcare, right? With education healthcare, everything was grant funded. You spent it when you got it. When you didn't get it, you made do with what you had, right? Startup mentality. This is interesting, right? We're all security, IT professionals. We think operationally, business, how are we going to support everything else? Most of the healthcare innovation are people in the industry, they're doctors, healthcare providers, whatever it may be, writing a widget, writing something to essentially improve care. They don't think about, enterprise authentication, logging, secure access, accessibility, all these different types of things. It's just not in their skill set, right? They're trying to solve a problem, and technology is going to enable that, but they're focused on one small piece of it, right? Test to production. I always love this when I talk to healthcare people. If you have a test is usually the bigger question. That's pretty much everything straight to production. Or, questions come up of, well, can we test this? How are we going to integrate it? It's well, we can't do it because, we've got all these windows. It's well, show me your test. Well, we don't exactly have one, right? So that's usually a big challenge. And then the last year it's highly sensitive, right? You have very, very vulnerable users, right? They're in the worst possible way in a lot of cases. You look at ERs and other emergency care. It's very vulnerable users, right? It's highly sensitive data. We're talking the entire stack of privacy data, credit card data, everything, right? And it's highly regulated, and it's getting very, very, very visible. I think this is kind of the next big thing. You're going to see a lot of healthcare breaches, and you're probably going to see a lot of regulations coming on the back end of it, right? So where does this leave us? It leaves us opportunity, right? We know what is sitting out there, right? So what are we going to do going forward to essentially understand the problem and start building solutions around it? So the Renaissance, right? Where do we go from here? Why? Users are demanding it, right? Patients, they're seeing everything going on. They're getting the constant notices of their data being breached and the privacy monitoring services. You look at healthcare workers, and a lot of the healthcare workers I talk to, they want mobile first. They want accessibility. They want to operate how they're used to operating, right? They want to get access to data and build systems. They want this capability, so they're starting to demand it a lot more. You're looking at generational changes. I talk about kind of the younger generations, mobile first, general accessibility. I hate to bring this up, but look at COVID, kind of the work from home, kind of work anywhere culture, everything else. Healthcare traditionally is very brick and mortar, right? You go to work, you work at a hospital type thing, but that's shifting with teledocs, with urgent cares. People are moving between care facilities constantly, right? And they want to bring their data with them. You're seeing a lot of consolidation. there's a lot of healthcare mergers, acquisitions. You're getting very big health systems, and they're trying to mash up multiple processes and patient bases and user bases and everything else. And it's adding more to the problem. And then maturity of standards. I think outside of healthcare and industry in general, there's a ton of great standards. I mean, go sit in every session here. Like, everything is maturing. It's getting very good, right? Healthcare can start leveraging that if we do it the right way. So how do we embrace it? Embrace the care. I know it sounds silly, but if their primary focus is care and we're putting up hoops around MFA, all the training and everything else that you need to go through to get access to data, we're pushing too much data on a screen, right? Why not take a look at what you're trying to do from a usage perspective and give them the tools easily to be able to do it, right? Recognize the shifts. Like I said, people that are moving, they want the work from home culture, they want to work from anywhere. We need to start embracing that, especially big healthcare institutions that want to attract talent, right? They need to go where the people are and how they want to work. No one size fits all. This applies to a lot of different things. I like using MFA as the best example. I've got, 8, 9 authenticators on my phone, right? Like, I'm going to get a push, certificate, passkey, everything, right? I'm going to do the strongest I can do. My father-in-law, he's got his Yahoo account, right? So when we're looking at solutions, we can't come in and say, oh yeah, we're going to do all this stuff. Well, you need to account for my father-in-law at the end of the day, right? Then reduce friction, clicks. How can we get people in faster? How can we use trusted devices, locations, context, everything else to essentially enhance security, but at the same time, enhance the experience of the users? I'm a huge proponent of MFA is actually going to be the downfall of security, right? Because we're losing intent of MFA. I mean, I get prompted everything I do. Every site I log into, I get an OTP, right? To the tune of, it really doesn't mean anything to me anymore because I'm constantly getting prompted. We start looking at adaptive capabilities to say, hey, you're always logging in from your workstation on this floor in this unit. All these other types of things, we're just going to let you in type thing, right? It's a known entity. We're not going to MFA you constantly every day for something you do normally. Let's start looking at context, other things like that. So shift away from the big platforms, right? EMR, EHR systems are huge platforms, right? They move very slowly, updating, making changes, everything else. As we kind of look forward and as the industry looks forward, we're already starting to see a lot of this, right? That the bigger platforms are looking at microservices, cloud-enabled, cloud-first type things, right? The more we can shift down, so to speak, to smaller microservices, there's less impact issues, right? One big platform goes down, everyone's down. One service that's a part of 150 goes down, it's not as big an impact, so you can actually absorb change a lot faster. Focus on services. Don't reinvent the wheel. There's a lot of the healthcare customers I talk to, are hiring from industry, not from healthcare, right? Because, outside of healthcare, they've got their way of doing it, but they're trying to bring in people that have done this before for other bigger institutions. Don't go it alone. Don't try to reinvent the wheel. Conferences like this are great, right? Listen to people, see what they're doing. Don't rush. I know it's very easy right now to say, like, we need MFA, we need all these different types of things. I mean, insert, issue X here. But if we rush, we're not going to focus on the actual problem. We're not going to fix anything. So take a step back for a second, plan it, right? Here's what we're going to do, why, and essentially strategically roll it out. Stick with it, get it done, right? A lot of the healthcare people I talk to are ridiculously smart, right? And they want to do it themselves because they've got a great idea and they want to help at the end of the day, right? Enable them. Reusable code, shared libraries, shared services. Enable them to do all the things we need in their context, right? They shouldn't have to think about, well, how am I going to authenticate, or where am I going to run this and everything else. Give them the services, give them the tools so that they can just focus on the widget they're writing or the medical device, whatever it may be. We need to do better with test to production, lower environments so that healthcare workers, innovators, everything else can actually build these things. The big joke I always make is we were doing decision support like 10 years ago, right? And it took tons of data. Like, it was going through our Epic system and doing all the handwritten note scanning and basically doing decision support, right? The person that wrote it was like, well, I need access to basically the production Epic because that's where all the notes are. And it's like, well, you can't do that. Well, how am I going to train this model to be able to do all this, right? We need to do better to essentially build in these processes to have relevant data sets in non-production environments, or build interfaces that we can anonymize and make some of this stuff accessible without impacting the actual main platforms. The high sensitivity, insert buzzword about security and everything right now, right? But these need to be commonplace, right? Start letting users know, like, hey, we're focused on zero trust, zero standing privilege, strong modern authentication, different stuff like that. Focus on security, not on compliance, right? If you focus on compliance, you're looking at a very myopic view. Focus on the best practices, the bigger picture of it, and plug compliance into that. I'm an old school GRC person, so it's like compliance and everything else is second language, but I've always focused on security and then basically report on compliance from that security. Obfuscation, anonymization, everything else. My background is research in medical, right? We had tons of data, and every time someone wanted to do a study, we had to copy these big data sets and everything else. There's a ton of very good tools out right now that you can publish these data sets, make them accessible for research or for volunteer, different services. I mean, going to the vendor hall, I'm not going to name vendors, but I know a number of them will actually do it on the fly, anonymized data based on context and users and everything else, right? The tools are out there to do this. So what's going to support this? Honestly, the last month and a half is probably going to be the biggest budget ticket, right? Like, look at these breaches, like how challenging this is. But at the end of the day, modernization, right? Everyone's looking at, hey, we're getting ready to do our refreshes, we're doing cloud migrations, we are merging and we're reevaluating technology in general. All this is going to contribute to essentially this renaissance that's going on right now. Standards, data sharing, identity sharing. I set in mobile credentials, verified credential sessions, right? One of the bigger challenges I have in healthcare is credentialing, right? Like, how do you verify licensing, credentialing, states, everything else? If a provider can carry that with them, or a patient can carry an insurance card and present it from their device at registration time, these types of things are going to drive a lot of change. And at the end of the day, drive a lot of security improvements. Culture change. Vendors are adopting standards. I can think of some of the bigger EHR, EMR platforms. They're starting to embrace these kind of modern authentication standards, right? Whereas traditionally, they had their way of doing it. So as they embrace this technology, industry is going to come in right behind with them. Then people changes. I'm starting to see a lot more chief people officer, chief medical, chief identity officer, basically focused on how are we handling this problem, and how are we embracing our people or enabling our people within organizations, right? So organizationally, the bigger health systems are recognizing this, saying this is what we need to do. So, a couple of practical examples. This is fun for me when I'm thinking about these things. But so what does this really look like, today? And I can say, me personally, I encounter these quite a bit, but you've got patients, providers, and business workers kind of on the left-hand side, right? These are all kind of the users and everything involved. And then you've got the payers, providers, and then services, data providers, cloud, everything else, right? There's a huge ecosystem providing healthcare services. Today, me as a patient, I go to my local urgent care. They refer to me to a hospital. There's at least 2 credentials there on top of my insurance and everything on the back end, right? And that's kind of a very myopic example. That's just me, not even my family. There's other things that need to be handled there. Doctors, depending on how many health systems you work with, you're going to have individual credentials at every health system that you're credentialed at. And then, if we're sharing health records externally, potentially you're going to have records or logins to the actual sharing platform, right? So we're just adding to this problem. And at the end of the day, you're setting the credentials the exact same. So what are we really helping here, right? And then business workers trying to support all this, right? All the people behind the scenes doing billing, ordering, operations, everything, right? They've got the same problem. It's just, they're different targets. On top of that, they're patients, so they've got a different login to be that context with the institution, right? So what could this look like? When we sat down and we're thinking about this internally, I mentioned I come from an education healthcare background, right? So In Common was just starting when I was doing this a number of years ago, right? It's much bigger now. But In Common is a great idea for healthcare, right? The idea being you've got this trust network that you can establish single, maybe a few trust points between the different institutions on the back end and give the actual consumers a singular identity or at least a single experience to get into multiple institutions, right? It's no longer, excuse me, me and Ben are competing organizations, right? Well, we need to establish a federation agreement between us that has to go through a legal review, and it just takes time, right? And at the end of the day, patients are kind of stuck with that bad experience. Things like In Common, these other kind of sharing networks, trust networks, whatever you want to call them, can start establishing easier relationships that, hey, Ben and I both trust Steven, my coworkers over here, so we're going to trust each other, right? I was talking to someone last week about this slide, and I'm going to kind of make the joke, but looking at this, the comment was, this is very aspirational, and I 100% agree, right? Because there's a whole host of hurdles we need to go through. Trust, technology, integration, everything, right? This is very aspirational, but I think these conferences kind of highlight that this is where we need to start moving and thinking about, right? Who's going to come up in the industry and kind of think up these things and start establishing this, right? I think it's going to be some of the bigger health systems, right? They're going to start becoming providers, or providing these integrations. Could be someone else. And at the end of the day, previous is aspirational. This is reality, right? We just finished this project here in the last couple months, and essentially we took what needs to be done at every healthcare institution and built it, right? So I had that middle layer, that identity exchange. Think of that as kind of to the left of the partners right now. All the back-end infrastructure that was needed to even enable that type of functionality, we're building it, right? And we're putting the APIs out there that this particular customer, as their partners create users in their HR systems and everything else, they can push this data and we can securely log them in using their home credentials into a hosted EMR platform, right? So we don't need usernames and passwords. We're not doing stub accounts. Sorry, I'm kind of leading into some of the vendors, but we're not kind of bypassing security. We're essentially building the infrastructure to enable it and more of a bring your own identity model. Some future releases and different ideas we have, rather than having the API start doing just in time. Like first time login, you get a nice little welcome. Hey, you're logging in for the first time here, right? Go request whatever template, sub-template access you're going to need to this environment, right? This is doable. Previous aspirational, this is step one, right? We actually need the infrastructure that can consume the aspirational stuff. Any questions? I kind of went through very fast. We got time. Yeah.
Where do you get that template data from the operations side?
depends. Today, it's usually coming from it's coming from a group that's defining those templates, sub-templates, everything else, right? There's a model we've built from a POC that this particular customer, I think, is going to start leveraging with a dynamic authorization platform that near real time, based on their organization, attributes about them, we can reach out and get their template, sub-template assignments on the fly. So as we're creating them, we get all that info based on an authoritative source and are doing the provisioning right there on the fly. Today, it's static. We get a feed, right, that updates a bunch of role assignments. It has templates, sub-templates, but we're looking at that next leap to say, that's a lot of maintenance. Whether you do it nightly, weekly, that's a lot of maintenance to go through all those assignments, attribute mappings, roles, everything, right? If we can step out of that and say, hey, you update the templates at your leisure, right? When I need to get them, I'll ask you what this person is authorized for, right? So essentially going to the source rather than exchanging data, more of a getting off of batch processing, so to speak. Yeah.
So a lot of the challenges I see here is the aggregation of data so you can make those decisions. One of the products I developed years ago or helped develop design was the IoT, the heart monitors, vital sign streaming. So as you look at that, you want to make decisions. I see very much a challenge, and that was a great presentation. But what a lot of these see is that if you don't have the right data to make the decisions, because you have, as an individual, your medications you're on, locations, your travel. So that's a great example how you showed the different credentials. Even when you leave the country and come back, you still have some of those same challenges because now you have international.
Yep. Someone asked me recently when I was talking about this, like why this is a challenge specifically in the U.S., right? And it's because you've got multiple insurers, providers. We are a consumer economy versus someone like, say, Canada and Europe, where you're getting into more like single-payer systems where it's consolidated and you can control it, right? We're, for lack of a better term, an open network here, right? We all got to trust each other. Like we don't.
Devices, right? We're wearing watches, we're wearing all these monitors.
Yep.
So to me, the control of those vital signs are critical. As a human, we have a little control with that asset.
Well, it's the vital signs and everything else. It's the data itself, but the authenticity of the data as well, because you said you developed heart monitor, like data IoT type stuff, right? Getting data off and analyzing it versus validating the authenticity of the data coming out, right, is some of the questions I start asking when I'm talking these things, right? I mentioned the decision support stuff. I asked a very simple question in a meeting that was like, all right, this is cool. I mean, like ridiculously cool stuff that you're building. What happens if you go in and change a line of code? Well, no one would ever do that. No. We know that's going to happen.
Well, the security back then, that monitor was built in 97, was streamed over 33.6 DSVD. And we watched this 12 lead ECG, it's an oxygen SpO2. No little security. You connected in the way you went, and the doctor's looking at, so
Yep.
fast forward to now, I mean, we're very vulnerable, I'd say, at this point, not only from our data, but
Yeah. Wouldn't disagree.
good presentation.
Thanks. Yep.
Yeah, in your overview of MFA, you seem to be advocating maybe user experience over security a little bit and minimizing friction. I know that, so I'm not paraphrasing exactly, but you also talked about passive forms of authentication down the bottom. I'm just wondering what types of technology specifically around passive are you advocating or having conversations with your customers?
You can look at device profiling. You can look at the adaptive MFA of Azure, Okta. Sorry, I'm naming a lot of vendors. Look at all those things. The example I like to use, you can look at device fingerprinting, certificates, trusted device, enrollments. I mean, there's all those different types of things, but at the end of the day, those are just additional authenticators. The adaptive stuff, that is a trained model that says, hey, you're always coming from this device around this time, everything else is much harder to beat. Yeah, a fingerprint. some other strong context around that session that we're not going to do anything additional. That's much harder to beat than, say, an MFA push bomb. Like, what is all the other terminology they're using right now? Essentially, it's just these constant pushes, and people are just blindly, they're not fatigued. There's no intent behind it. There's no meaning because they're used to just hitting approve. I'm guilty of it. I know I am, right? I'm logging in the morning, and I get my prompt, and I'm just accepting.
What forms of like non-passive authentication do you recommend? I guess it depends on the use case, whether it's patient focused or worker focused. Like when you talk about the different methods you're seeing or advocating, all forms beyond passive, more around the active MFA.
I mean, specifically in healthcare, the well, it's going to be all of them. You know, honestly, like I said, it depends on the use case, the user base, you know, how they're using it and everything else. I mean, obviously, the modern push, kind of phishing resistant stuff is going to be best, but that's only going to account for probably half of your use cases, right? What are you doing for that other half? You know, that's going to be where you start stepping down and saying, all right, well, we're going to allow OTP, but we're only going to allow it from these locations, and we're going to start anonymizing data when you're using these types of factors, right? You can start looking at that kind of risk lever to say, hey, we're going to allow it. We're going to start ratcheting this down. You know, remote access is a good example. Like, hey, I'm a provider. You know, I'm on vacation. I don't have my work phone with me, but I need to do something, right? Something quick. Well, maybe you allow an OTP for like an anonymized session or kind of a secure web browser, something like that they can't exfiltrate data, right? Something along those lines. And you send alerts. Like, hey, you just did this. If it's not you, let's start knowing, right? But you can start looking at these kind of step-down approaches of, hey, this is a very strong authentication. We're going to open up everything you need to do. Versus, hey, this is kind of a point-in-time type thing. We're going to allow it, but we're going to start kind of ratcheting up the controls. Like, I'm talking about PAM this afternoon, right? Privilege access management. The number one question I always ask people is, how do you define privilege, right? Is it just by having an account? Is it being a part of a network? Where are you coming from? What are you accessing? They're all privileges technically, right? So PAM, in this use case, could be an avenue, right? Like, hey, you want to do these types of things. We'll publish a secure web browser that, you know, restricts copy paste, restricts access to data, different stuff like that for these kind of myopic use cases, right? Because you want to enable people to do what they need to do, but not be locked down or overburdened with carrying everything they need to do it, right? So it may not be just an MFA factor or a device check. It could be the infrastructure that's actually pushing it. So you could look at the secure remote access, the secure web browsers. I just looked at an enterprise secure browser recently.
Island, maybe?
What's that?
Island.
Yeah, it was one of those. But basically they were using those via Citrix and everything else to start locking down access, right? We can start talking about these types of things. It's not just an MFA or a device profile. You know, I think that's a part of it, but there's a bigger picture here. So the vendor I mentioned that is anonymizing, and I was working on the template stuff with, is Plain ID, just being honest, right? They can sit in front of that data layer and say, hey, you're coming in via this insecure means, right? We're going to, on the fly, start restricting or obfuscating data so that you can't do it, right? These types of things don't require big infrastructure improvements. They just require architecture, right? They require integration. Excuse me. And what you can do is you can layer that stuff into their template, sub-template. Say it's an Uber provider, right? They got access to everything. Well, when we make that authorization decision, we can build that into the context, right? Not only am I provisioning their medical access, right? When I make an authorization to that secure web browser, I can see, like, hey, this guy has access to everything. Like, I'm not going to allow it, right? So we can start building in context not only for provisioning, but also access as well. You know, these are business decisions, not technical decisions in a lot of cases. I mean, it requires budget, unfortunately, to build these things out. So it is a business decision, but the technology is there. It's just a matter of kind of pulling it all together.
I think the use cases are very unique compared to the rest of the industry sectors. If you look at it, you got people's lives, vulnerabilities you pointed out. I think it's a lot different than
Yeah, I was talking to someone recently, in your example of like lives, right? I can walk into most of my non-healthcare customers and you can confidently say, well, no one's going to die if we take this down type thing, right? Healthcare, you can't say that. You take it down, it's going to be down. The Ascension stuff, that's 10 minutes from my house, right? I'm talking to different friends of different ministries across the U.S. that they got notices almost immediately to start redirecting all non-emergency cares, all procedures, everything. So now you're affecting actual healthcare. If I have to drive an extra 10 minutes because the hospital can't process me, that's kind of important stuff. Mm-hmm. I mean, that's a use case of the actual care. The doom and gloom side of me is I'm going to leverage that and call those clinics and basically impersonate like, oh, I'm coming down really bad right now. I need my meds. I don't know my login because I can't think straight right now. Like, can you just prescribe this or give this to me or reset my credentials so I can get in and do this, right? These types of things happen. Attackers know this. Yeah. Yep. Well, I'm not saying that MFA could have helped prevent it. That's the tagline, the headlines coming on the news. That one headline I had at the beginning there, that was a dark reading headline. The urgent need for MFA could have fixed this. No. I mean, me reading into it and kind of working with a lot of healthcare, right? There's a lot of Citrix, there's a lot of NetScaler, everything else. Unless you do a ton of Citrix, right? Like getting the SAML, the modern authentication into those types of environments is very challenging. It doesn't work as easy as it should sometimes, right? So these types of things, it could be a vendor support restriction, it could be a device that they have out there. Maybe the use case when they originally built it wasn't for remote access to patient data and everything else, and no one thought about it after the fact. I mean, there's a whole host of things we could say. I mean, yeah, you can enable MFA and Citrix, with their CAGs or NetScalers or whatever they're calling it now, right? You can do the SAML. But at the same time, the immediate reaction from the news is like, oh, we should MFA this. Should we? I mean, yeah, I'm not advocating not MFAing by any means, right? It's very effective. But at the same time, let's look at it appropriately to say, yes, we're going to integrate it with all of our other modern authentication, which MFA is a component of that. Yeah.
Are you seeing much adoption of passkeys?
No, not yet. It's device support, general knowledge of it and everything else. I think it's really cool, and I think it's going to come fast here, but I have not seen much adoption. I mean, I know my iPhone, Google Chrome, it's coming, right, from a device support and accessibility and everything else, but it'll come at some point. I'm not seeing it as much yet.
That's because the industry is a laggard in some areas. That was one of your observations.
Yeah. Well, I mean, healthcare is always going to be at least, I say 1 to 2 kind of versions behind. That equates to probably like 4 to 6 years, right?
So you're not seeing increased conversations or activity around passkeys?
I'm having a lot of conversations around strong authentication at this point, right? Passkeys being one of them. But you need consumer technology on the other end of it that can actually accept passkeys, right? The Change Healthcare, which was just a standard username and password interface, passkeys wouldn't fix that, right? So we actually need the technology that can support and accept these modern authentication, and then we can start enabling and pushing it down into the industry. That's the bigger challenge. It's kind of putting the cart before the horse a little bit sometimes. I mean, there's great stuff out there. There's very strong. Can we support it, right?
So FIDO was established in 2009. It took us, what, 17 years to get here. So why so long? Like, why would I believe in passkey? It took 17 years.
Honestly, that's a good question. You know, I guess there's... Oh, well, I mean, I would look at it kind of a couple of different ways, the FIDO versus passkeys. I think passkeys has gone through a lot more public scrutiny from a community. FIDO being more device specific versus passkeys that are more browser based and everything else. I mean, there's a lot of things we could look at, you know, from a general adoption. But, you know, there's tons of strong authentication out there. You know, there's new stuff coming right now. At the end of the day, though, we need to bring the infrastructure up to start accepting these things, right? We need to do it in a meaningful way that works with our workers. You know, if we move to all FIDO or push notifications and everything else, imagine the nurse that's sitting at a bedside with her gloves, mask, everything else on, trying to do, you know, click a push, right, when she's all scrubbed up. My mom was a surgical tech. As soon as you walk into a room, like, you can't touch anything. If they're trying to log into a device and, you know, you're all scrubbed up, and you're masked up and everything else, it's not going to work. So.
You're resistant to using your own device to talk too much about that. Doctors, you know, they don't like you to push notifications to their device. They don't want to put software on their device. Interesting culture.
So I get this question a lot of, like, how you handle personal devices and everything else, right? I'm not sure if this would ever come, but I've had this conversation with a lot of people. But how do you get them to use their personal device? You make it personal, right? The biggest risk of running all this infrastructure, building IAM and everything else, is the credential itself. It's the authentication, the password, right? If we can take password out of the equation and start trusting, I'm going to use a 4-letter word here, but Facebook, Google, LinkedIn, right? As an initial authenticator, or at least an assertion of someone saying who they say they are, and then we're layering in all these other modern authentications. That phone now is very personal to them because it's their credential that they're using to log into the systems you're providing them, and you're just kind of adding your secret sauce, your authentication on top of it, right? I'm having this conversation more in, like, high turnover environments, you know, retail and different stuff like that, because they want to get people in fast, and help desk, call volume, password resets, provisioning, like, these things are very, very challenging. So how do you get rid of all that? Well, you take it out of their hands and make it something personal that they use every day. There's nothing that says that is an authentication. That's just an assertion of someone saying, you know, or getting it from Facebook. You're going to authenticate with the device profiling, the strong MFA factors, everything else on top of that. That's much easier to control.
We'll say the commentary on what you said, there seems to be a generational divide. Older clinicians they want to keep their work and their home device separate. It's a tool, give me a tool to use to do my job. And younger clinicians are like, let me pop up one device, I'll do it on there, I don't care, just put all my stuff on there.
Yep.
And they know to just use that app versus say their own personal app.
Mm-hmm.
So the not one size fits all solution recommendation would be definitely applies. Just the authentication.
And it's surprising how many people don't know their Apple ID.
All day, every day.
But there's also kind of other extremes. You mentioned personal devices. I worked with a provider a number of years ago that didn't want anything. Like, he had his PA following him around, basically telling him the code to type in, or she would type it in for him because he didn't want to have to carry an OTP, right? Very strong personalities. Yeah. We joke, but I'm sure we've all seen it. So.
You talked about change-resistant culture and using modernization as a way to chip away at that. Like, what about modernization? You said care and security.
So, to me, specifically in healthcare and modernization, is more the generational shift. The gentleman over here mentioning, people wanting to do everything from their mobile devices and everything else, right? That requires a good amount of infrastructure to do it, right? And at the same time, a lot of people are moving, I hate to use the term cloud, right? Like when we're doing cloud migrations. But they're looking to move off of, major data centers, infrastructure, everything else to cloud-based platforms, right? So you can leverage all this as an idea of like, hey, we're going to still support our bread and butter, from a workforce, general use cases, but at the same time, as part of this migration, we're going to start building in all this accessibility, on this new platform, right? So when I say modernization, it could be upgrades. That's kind of one component of it, but I think it's more the cultural shifts in accessibility, operations. Budgets are shifting a lot. They're trying to operationalize, which is the bigger cloud push and everything else, right? Get off capital, data centers, power, cooling, everything else. I mean, we built a building when I was at the hospital just for our data center. It was massive, right? That was a huge cost, and it was a very visible building in the middle of our campus, right? As we're moving off of that stuff and you're looking at your DR, BCP, everything else. Anyone likes reading Rita Haas by Dr. Steve Timmons, Holistic Organizational Survival? We're evaluating all this type of stuff and we're moving to the cloud. This can all be a part of that, right?
So I'm from the University of Rochester. We just built a data center. But it only takes one position. So all the momentum that we have and all the early adoption that we have from people within the university, it takes one powerful position to undo that. So how do we push back?
You got to have strong leadership, unfortunately, right? I'll kind of add on to your example. You work at a university. I did the same thing in University Health System, right? We did research. And there were a number of docs that specifically got recruited, and they brought their own servers, their own equipment, and basically put it under their desk. And this was like super sensitive data. They're like, well, I'm so-and-so, I'm going to do this. And our organizational review board that actually approved all the grants and funding and everything else basically said, no, you're not going to do it. If you want to work here, you want to leverage all the compute services, everything else that you can do here, you got to integrate with our stack. But we had a very,
They say they'll take their grant money somewhere else.
you know what? Some may, but at the same time, the bigger cost right now, I was just reading a stat, was it going to be $600 million impact for the Change Healthcare? Something along those lines. Between organizational revenue, customers leaving, I mean, it's going to be big. It takes one of those. Yep.
So I used to work for a large healthcare up in the Northeast. And one of the things that we did was build it into the tenets of executive leadership. Most executive leadership is sponsored by or represented by doctors. You bring in there that one of the core tenets of operating or your business objectives is security, is these tenets which you live by and which we're going to go through. We had doctors that came in, both from a new perspective, saying, well, they're going to bring POIV in, regardless of policy, or they're going to bring computers in. It was met with a resounding no. Ultimately, no matter what doctor comes in with, however inflated his ego is, he still has to report to someone. And that person is going to have to say no.
We built it into our reviews, and we built resourcing in to enable the doctors to leverage our facilities. So, we had 60, 70 people in my department. Probably half of them worked for researchers, basically integrating their development and research and everything into our technology stack. So that way they didn't have to think about it, and they didn't have to, maintain, ownership, right? Like, this is my data. It's underneath my desk. Like, no, we'll take care of it for you. We'll give you all the access. We'll even help you share it. One of the instance I had a number of years ago, someone published a database credential because they're like, well, I want to share this data. Here's an Oracle database port and username and password. Go at it. Right? So we essentially sat down with them and said, like, hey, you don't have to think about this. You want to do something, you focus on your research. We'll build the services, help you integrate it, we'll host it, kind of take care of all this stuff for you, and there's no charge. Or there was like a minor technology charge at the end of the day. We were funded to do this.
Yeah, it's also financial.
Yeah. I mean, if I can go buy a Dell server for $500 versus, kind of a small business Dell server, I run a data center at home. I can buy a little Nook for $600, right? That versus, hey, you have enterprise storage, you have enterprise class server, multiple power. I mean, that can be $5,000, $10,000 when you start adding all that stuff up that they don't have money in their grants to do.
Another example I think that we've seen, and I work with Nick on a number of these, we've often, with customers, tried to pair the care and sick for the medical professionals. So Chris and I worked on a large project in the Pacific Northwest. They had a huge problem with identity proofing of their credential provider. That was going to be a labor-intensive process of moving the person's systems. So we're able to pair that with password reset and with a caregiver reduction in time. So it wasn't just looking at an MFA or an IG, it was trying to take 3 or 4 of these combined together. And we found that we were greasing the skids almost to say, hey, listen, we understand some of the security protocol burden. Here's what we're going to help you with on the enablement side. And that seemed to get things moving in, gets through some of those objections. But you got to look at that up front, and sometimes that's a hard I got funding for an identity proofing project, and we're like, that's great. You've got to look at the other pieces that you can sell this to more, because you're at one group of very vocal people.
Yeah, it would be great to do that. Like
Yeah.
we looked at one hospital. At least getting the funding to.
And listen, there's a ton of it. Page's got one. I think DataWeb they're all looking at some of those, but that was a very big driver for them for security. And we were able to pair it with that kind of carrot on the new caregiver orientation, which is completely separate technology. And that seemed to move things well, and it had a good reception to it.
Yeah, that is interesting because a lot of the workforce now, we've got a lot of employees and we push them through an I-9 process and we know who they really are because of the government requirements. But then you start to, and providers really know who they are before they do it, especially with their providers. But when you're looking at the sort of the wider workforce where you've got a lot of contract labor or people providing services and staffing, you don't really have a lot of control of who exactly is the person. So with a number of organizations who've really taken us through the process that when they're registering those people, it's at that point that we go through the identity proofing as well. So it's not seen, it's just seen as part of the onboarding process.
Yeah, and it's seamless and it halts the dirty data that we get further.
Well,
down
it
the
cleans it up, right? Yeah, for sure. And then they're providing the data because it has to match the driver's license.
I mean, correct me if I'm wrong, but one of the other kind of byproducts of that, outside of the help desk call volume, improved security and everything else, is people actually felt good. Like, hey, I got this welcome email, and it kind of walked me through, and I was up and running. So there's other kind of soft, benefits, if you want to call it that.